So the session that I was directly involved with was a debate. I thought a very stimulating debate with a colleague, Robin Foa, from the GMEMA trial group in Italy, a good friend and also a member of the European Working Group on Adult ALL. And the content was transplant in Philadelphia positive acute lymphoblastic leukemia. And we were supposed to argue our two positions. His position was no, and my position was yes. My reasoning is that although ultimately all of us would like to get rid of allogeneic transplant because it is an invasive treatment modality, if we look at the long-term mature outcome data, then it is the best, most tried and trusted approach for a curative therapy. Of course, there are a lot of developments, and not every patient is a good candidate for transplant. But I do believe that we have, with increasing improvements in transplant technology, moved up, for example, the transplantable age of patients. The supportive care has become better, and the matching of the donors has become better. Introduction of haploidentical transplant essentially makes every patient have a donor available. So against that backdrop, the question is, can you avoid transplant, and how do you identify those patients in whom you potentially can? And the surrogate marker that is commonly used is so-called minimal residual disease, a very low-level disease that you can't detect in the microscope, but you can detect with sophisticated molecular methods. And my point of the argument is that a surrogate marker is fine. It does give you an indication of how the patient may do, but that really long-term survival results, especially survival without recurrence of the disease, is really the hard evidence. And on that basis, I come down very strongly in favor of allogeneic stem cell transplantation as the gold standard, which one should always consider. There will always be reasons not to want to transplant an individual patient, starting from patient wish and choice to comorbidities, age, other circumstances. But one should formulate a very good argument for not transplanting. So that is, I think, the major distinction in how we interpret this minimal residual disease, where exactly to have the cutoff, for example, by age and a decision to transplant or not to transplant. Fundamentally, I think that the positions are not that disparate as they might appear, and they're supposed to be at the debate, which is supposed to be lively, stimulating, provocative, confrontational, but actually we all recognize that you have to individualize a decision to an extent. And there we meet pretty well in the middle. Well, increasing age certainly is a factor that we have to consider. The age threshold is moving upward over time. We actually recently completed a trial for elderly Philadelphia positive ALL patients in frontline therapy. About a third were transplanted, although it was not part of the protocol, but the protocol permitted this, and the median age of those transplanted was 61. And the oldest patient transplanted in that group was 69. So that just shows you that you will have individual patients who are biologically so young and so fit that despite the chronological age you would consider it. And that is a decision that you cannot apply a mathematical algorithm. It's a lot of experience that goes into it. But on balance, age is one aspect. comorbidity, so if somebody has severe heart disease, a severe pulmonary disease, renal insufficiency, I mean, you can name a lot of diseases where you know by experience that the risk of the patient either dying or having long-term damage is just so high that you wouldn't want to transplant that patient. The issue of MRD, I think the importance to recognize, and Robin Foa, of course, sees it exactly the same way, is that it has to be very robust data. MRD is not the same depending on which lab you look at it. It should be a reference lab, accredited lab with a good track record, which delivers the data in a timely and prompt manner. So that is the third, and I think that is an area that will be beginning to evolve more and more, is the role of genetics. So that we will, we know that there are patients who have a genetic makeup of their leukemia, which despite an initial good MRD response, are unlikely to do well long term, and possibly even with transplant. And so by combining these different factors, I'm pretty sure that over the next few years we will be better able to identify those patients with different parameters who should proceed to a transplant ideally, or who should be spared a transplant and be moving to other therapies. And what the point that Robin very strongly made in his debate was the future outlook. He emphasized that more than I did, because I said robust data, and he was looking at the forward trajectory. And I think both are very complementary aspects. And I think we agree that there is a huge amount of hope in the developing immunotherapies, but also the combination treatment and a number of new drugs and also new drug classes that we're just beginning to test in ALL and Ph-positive ALL. And if we move all of these up to the front line when the disease is most susceptible to treatment intervention, I'm pretty confident, as Hervé Dombré said in this final conclusive statement, we will cure ALL, but it might still take a few years. So the first goal is to achieve the best possible response with ideally minimal toxicity, so that the patient is in a good condition, and then look hard and strong at the transplant option, and then make a very well-educated decision together with the patient. That's incredibly important, based on the evidence that you have, and ideally within a clinical trial. I think we can't overemphasize the need to treat patients within clinical trials. The results, even with the same treatment, are better for patients in clinical trials than outside of clinical trials, because the oversight is more intense, more rigorous. Checks and balances are, intrinsically more rigorous, and also one usually has access to the cutting edge treatment options, which are not available, outside of a trial. I thought it was a very stimulating meeting. Certainly, I'm looking forward to next one. And there is a incredible dynamic in the field, which is really heartening. And I think we will be benefiting the patients immensely over the next couple of years.